Good day, my name is John Conceição. I'm the EMS System Director at South Middlesex EMS in Cambridge, and I'm making this brief video introduction for staff members who may be receiving patients receiving the new CCR cardiac resuscitation procedure. Beginning next Monday in Cambridge, members of Cambridge Fire Department and professional EMS have received approval from the Department of Health in Massachusetts to perform a new form of cardiopulmonary resuscitation known as CCR. This new form of resuscitation, Cardio-Cerebral Resuscitation, focuses on providing closed chest compressions as typical CPR does, but in most cases, for the first 8 minutes of resuscitation, no ventilation is delivered whatsoever. So when EMS crews arrive on scene, they will begin an initial ABC assessment, and if the adult patient suffering a non-traumatic cardiac arrest of non-respiratory etiology is identified in cardiac arrest, CCR will be initiated. This means that one provider will begin external compressions at a rate of 100 compressions a minute, which is the current AHA recommendation for healthcare providers' CPR. The second rescuer will place an oral airway and a non-rebreathing oxygen mask, typically the type that we would place on a patient that is breathing spontaneously. As CCC, or closed chest compressions, continue, the second rescuer would then attach either an AED or a manual defibrillator and perform rhythm analysis and defibrillation as required under current ACLS guidelines. For the first 8 minutes, the entire cardiac resuscitation comprises closed chest compressions, defibrillations, the placement of either an IV or an IO, and then only the administration of epinephrine, 1 milligram every 3 to 5 minutes throughout the duration of this first 8-minute period. If at any time the patient develops return of spontaneous circulation, or ROSC, standard post-resuscitation algorithms will pursue. Here in Cambridge, this would include endotracheal intubation, potentially additional IV placement, and the administration of chilled hypothermic fluid for the duration of the transport to the local hospital. Now, when the patient arrives at the hospital, you may see several changes. Some patients may come in intubated with external compressions ongoing, as you're used to seeing for the past 5 to 10 years. However, if the patient arrives early during the resuscitation period, they may be receiving external compression only, either manually or with the use of the Lucas external CPR compressor, with no ongoing ventilation. Now, once the patient is delivered into the emergency room, it's up to the attending physician to decide what procedures should be accomplished next. CCR has been shown to increase survival from sudden cardiac death by up to 300% when compared to traditional 2005 ACLS guidelines. However, the benefits of this additional survival from cardiac arrest have been seen within the first 8 minutes of collapse. So if the patient does not have spontaneous circulation by the end of the 8th minute of this new procedure, typically the results equal those of traditional 2005 CPR. So from the standpoint of ongoing resuscitation procedure, once the 8th minute of CCR has been completed in the field, the pre-hospital EMTs and paramedics will convert to a traditional ACLS approach with all of the medications, the airway management, and the ventilation that is currently recommended under the 2005 guidelines. Now, each and every case of CCR will be carefully reviewed and compiled and will be submitted to the Department of Health on a quarterly basis. It's our hope that we will be able to reproduce the exceedingly high outcomes, especially from witnessed ventricular fibrillation cardiac arrest, that have been reported in several other areas of the United States. As far as the future goes, it's important to recognize that this fall, November 2010, the American Heart Association will be releasing new guidelines for both CPR and ACLS. And it is very likely that the guidelines that we're using right now in Cambridge will be a substantial part of the new recommendations that we'll all be learning beginning this time next year. If you have any questions regarding this procedure or any comments or feedback regarding patients that are delivered to your facility, please feel free to contact me at 617-868-4848 or my email, which is smemsdirector@aol.com. Thank you.